Good afternoon, and welcome to Millsaps College. It's my privilege to serve as president of Millsaps, and I'm delighted to be with you all this afternoon for this important occasion. A little over a year ago, many of us were here today gathered in the same room to reflect on and celebrate the Education Reform Act of 1982, and also to discuss the ongoing challenges facing public education in Mississippi. In his introductory remarks from the podium, Governor William Winter, who's with us today with Elise, helped us all feel like we were part of history, vicarious participants in that historic 1982 legislation. And as he does perhaps better than anyone else in Mississippi, Governor Winter reminded us that the success of our state requires courage and commitment from all. As the president of Millsaps, I must say that one line of Governor Winter's remarks that day had a special impact on me. He began his comments by saying, "Millsaps has been an intellectual oasis in Mississippi for a long time and has provided an inspiration to many of us." The governor's words were, of course, flattering, but perhaps even more importantly, they were inspiring. Governor Winter gave us a charge to make the most of our rich heritage, our location in the heart of Jackson, and our commitment to asking and trying to answer difficult questions. I wasn't the only one that day that left the discussion inspired. Following that panel, two generous alumni of Millsaps who heard Governor Winter's remarks that day made an anonymous gift of $100,000 to establish the Elise and William Winter Speaker Series at Millsaps College. The series honors the spirit and determination of Elise and William Winter in their decades-long fight for a better Mississippi. And the endowment, which is held at the Community Foundation of Greater Jackson, will help ensure that Millsaps can continue and expand opportunities for students, Jackson citizens, community leaders, and others to discuss matters of public significance. Millsaps is deeply grateful to the donors for establishing a fund that will help ensure continued success of our public forums and that will reinforce a key component of our strategic plan entitled Across the Street and Around the Globe, Partnerships and Influence at Millsaps College. We believe at Millsaps that we have the opportunity and a responsibility to bring important topics and speakers to the public's attention and to be a public square of sorts, and we're especially pleased and honored to have our name linked with Elise and William Winter through this gift. If discussing topics of public significance is the goal of the series, it's hard to imagine a more fitting topic than the Affordable Care Act and its implications for Mississippi. Few political issues have sparked more spirited and at sometimes vitriolic debate than the Affordable Care Act. While today's panelists have been encouraged to share their opinions and experience freely, the purpose of today's discussion is not to convince anyone to change his or her mind about the Affordable Care Act, but rather to provide information and to create an opportunity for dialogue on this very important topic. So regardless of one's stance on health care reform, most will agree that the Affordable Care Act is complex and at times confusing. We hope that today's discussion clears up some of that confusion and in the process helps us to become better informed and more engaged citizens. To that end, in mind, we have an extremely knowledgeable, experienced, and accomplished leaders from fields of government, medicine, insurance, and legal advocacy with us today. Mike Chaney serves as Mississippi's Insurance Commissioner and has been at the forefront of implementing the Affordable Care Act in Mississippi. Mr. Chaney has been vocal in his support of creating a state-based health care exchange in Mississippi, and I'm sure that, among other things, he can help us better understand the questions and controversy surrounding whether or not to adopt such an exchange. An attorney from Mississippi, Senator Hob Bryan, has served in the Mississippi legislature since 1984 and is currently vice chair of the Senate's Public Health and Welfare Committee, a committee that is tasked with navigating the increasingly complex relationships between state law and federal guidelines and requirements. Ms. Linda Dixon Rigsby comes to us today from the Mississippi Center for Justice, where she serves as the center's health law director. Ms. Rigsby, and the Center for Justice are focused on removing barriers to health care access for Mississippi. Prior to joining the center, Ms. Rigsby was Assistant Secretary of State for Elections for the Mississippi Secretary of State's office. Representing the insurance industry, Dr. Tom Fenter, a 1966 alumnus of the college, is Chief Medical Officer at Blue Cross Blue Shield of Mississippi. The Affordable Care Act requires insurance providers to add previously uninsured individuals to their roles, which means that private insurers such as Blue Cross and Blue Shield have new opportunities and new challenges in the days ahead. And finally, Dr. Tim Alford, who will be our moderator today for the discussion. A 1978 graduate of Millsaps and a member of Millsaps Pre-Medical Advisory Board, Dr. Alford is a former president of the Mississippi State Medical Association and a family physician in Kosciuszko, Mississippi. As a primary care provider, Dr. Alford deals daily with the concrete realities and challenges of providing access to quality health care for Mississippians. So please join me now in first thanking my assistant, Kenneth Townsend, for putting this program together. And now join me in welcoming our distinguished panelists. Thank you very much, Tim.
Can you hear me now? Thank you, Rob. I wanted to lay a few ground rules. It's my understanding that there are note cards at the end of each rows. Could we go ahead and distribute those now and get them out into the audience? Because as we go down the line here with our panel and hear their remarks, it could provoke a question. So what's going to happen is when you get your question, just go ahead and pass it, I suppose, to your left. And Kenny will pick those up, and Kenny will filter those and bring them up here so we can have some audience participation as we move along. I am a family physician in Kosciuszko. I also have a few other little jobs sprinkled around our beloved state. One of them is I sit on the Rural Scholars Commission, which is something that Senator Bryan helped us procure. We now have 60 rural scholars in the pipeline who will move out and filter out into the state with the hope of more coming. This is a definitive move that those of us in the primary care community felt like needed to happen so that we could more proactively address the primary care shortage in Mississippi. Also, I work with and sit on the Commission for the Physician Workforce, which is a newly created entity that's now housed at the University Hospital, which will begin to look at the needs of physicians across the state by specialty type and begin to actually give us some hard information about what physicians are needed where. And it is a very important part of what we'll be talking about today. So the topic at hand is the Affordable Care Act and how Mississippi fits into that. And as you know, this act was set into motion 3 or 4 years ago, and it has gradually unfolded before us. And I think I will call on Linda Dixon, Linda Rigsby, who is sitting to my right, because I think she has some comments to make about that very thing. So I'm going to turn it to you, and then we'll just move down the line. Panelists will introduce themselves and orient you to where they're coming from. Thank you.
Thank you so much. Hello, everyone, and I'm so happy to be here today. This is a wonderful opportunity for us to talk about the Affordable Care Act. My name is Linda Dixon Rigsby, and I'm an attorney with the Mississippi Center for Justice, where I serve as the Health Law Director. The Mississippi Center for Justice is a nonprofit public interest law firm. In addition to health, we also have a focus on education, housing, consumer protection, and other issues. We have 3 offices, one located here in Jackson, one on the coast in Biloxi, and one in the Delta in Indianola. As far as our health law division, the work we do is access to health care and HIV. We recently, the Mississippi Center for Justice, the Mississippi Department of Health, and the University of Mississippi Medical Center and the Jackson Medical Mall just recently collaborated and formed a partnership to have the first medical legal partnership in our state where we serve people living with HIV and AIDS who have, we provide free legal services for people who have been discriminated against with employment and housing violations. So there's about 200 in the country, so I'm very happy to say that Mississippi has had its first to serve people living with HIV and AIDS. In our access to health care initiatives, we are currently focusing on implementation of the Affordable Care Act with an emphasis on consumer protections in the Affordable Care Act and how it pertains to children and families. In March of 2010, the Affordable Care Act made sweeping changes to the way Americans will access and use health care in our country. And I just want to share with you today some of the major components and provisions of the Affordable Care Act and how they pertain to consumers. Young adults can now stay on their parents' health insurance up until the age of 26. And this is very important because, you know, before you reach a certain age and the young adults, they kind of gamble with their health care and they got insurance maybe, or maybe they didn't, depending on, you know, what their income was and starting out in life. So this gives our young adults an opportunity to go out into the workforce, graduate, and get settled and remain on their parents' insurance up until the age of 26. In addition to that, another provision is foster children can remain on Medicaid, so they can be in line with their counterparts, and they can remain on Medicaid up until the age of 26 here in our state. Children with pre-existing health conditions can no longer be denied health insurance. 6 months after the Affordable Care Act was passed, this provision was implemented in the states, in the country, and in our state. So this is a wonderful protection for children who had pre-existing conditions. As of January 1st of this year, that also now extends to adults. Adults who have pre-existing conditions can no longer be denied health insurance, and that's a huge major protection. We all know someone who has had a pre-existing illness and has been denied health insurance or reached a lifetime cap, and they no longer were covered. So this is a major benefit for all Americans. You may not have a pre-existing condition now, but there may be something that would resurface that would prevent that from happening. The Medicaid and CHIP requirement in our state, the face-to-face in-person requirement, where a beneficiary at enrollment and recertification no longer has to go in person for a face-to-face interview. The Affordable Care Act eliminated this practice. Previously, you had to do that. And this is really huge for people who live in rural parts of the state who don't have access or transportation to get to a Medicaid regional office or an outstation. You can now apply for Medicaid or CHIP by phone, by mail, internet. So this is a huge opportunity for people to gain access to care in that way. Now, under the Affordable Care Act, there are tax credits to help moderate income Mississippi residents purchase private health insurance through the Marketplace Exchange. The Marketplace Exchange is where people can shop now for health insurance, and this was another provision under the Affordable Care Act. And there's another opportunity I want to end up with and move on to the next speaker, but I just want to mention the opportunity that we have not taken under the Affordable Care Act that's not mandatory. You have to opt into this provision, but it's to expand Medicaid to health care to adults between the ages of 19 and 65 to expand Medicaid for those who live at 138% of the federal poverty level.
Thank you, Linda. Senator?
My name's Hob Bryan. I'm in the Mississippi legislature, which has never been described as an oasis of intellectualism. I had been informed this was a Methodist institution, and I come here and I see all the pews in the front empty and the back rows full. As a Baptist, I feel right at home. It's difficult for me to utter the words healthcare system because it ain't anything approaching a system. But the healthcare system that we have in this country is just bizarre. And I think that anyone who looks at it objectively will come to the conclusion we cannot continue going the way we are. We need to make some changes. There are numerous ideas about what should be done, but to simply defend the status quo, I think, is not very productive. Let me talk briefly about one oddity of the healthcare system in the United States, and that is that your healthcare is connected to your job. What sense does that make? What rational basis is there for healthcare being connected to your job? It grew up because of, I understand, wage price controls and fringe benefits and who knows. But that has some bizarre consequences. If you have a pre-existing condition, or you're in a group that's not a good risk, it's difficult for you to leave your job and go out and get an insurance policy on your own. If you have a pre-existing condition, it's just about impossible. Well, that results in people obtaining jobs and remaining in jobs, not because that's where they want to be, or where economically the invisible hand, I guess, would send them to work or whatever. They're stuck in the job or desperately trying to get a job for the purpose of health insurance. There's an economic cost in all of that shifting around of where people want to work. Okay, if this is a problem, how does one go about fixing it? I guess if the Democrats had their way, if we have to talk about this in partisan terms, the Democratic solution, I guess, would be Medicare for all, or single payer, where the government would pay for everyone's health care, but one would continue to seek whatever provider he or she wished. Again, that's Medicare. The Republican suggestion over the years has been essentially to have insurance companies who would negotiate prices with various providers, and in order for people to shop around, you would have a health care exchange. And this would allow individuals to shop from insurance company A, B, C, and select a policy. Okay. If that's the world you're going to have, there are a couple of things that follow from it. Number one, no insurance company can just sit here and say, I'll make insurance available at the going rate to anyone, because what would happen is all the bad risk, all the people with pre-existing conditions, all the people with very expensive conditions would immediately sign up, whereas healthier people would be less likely to sign up. You'd get a bad pool, and it couldn't be sustained. Well, okay, that's a problem. How do you deal with that? The way you deal with that under this system is you require everyone to have insurance. So if everyone has to purchase insurance, then when you offer a policy, you're offering a policy, and the theory is you'll get a mix of good risk and bad risk and on and on and on, and that system will work. But it is essential to that system to have a mandate that everyone purchase an insurance policy. Okay. So the Affordable Health Care Act more or less follows that pattern. Well, immediately then you have the criticism that requiring everyone to have an insurance policy is unconstitutional and socialist and, I guess, communist or whatever the cuss word of the day is. And then because states have the opportunity to opt out of these healthcare exchanges, a number of states, to express their displeasure with the Affordable Care Act, began opting out of the healthcare exchanges, which forces the United States government to operate a much bigger proposition than anyone ever thought. And a lot of the objections to the Affordable Care Act are just based on emotion, not based on reason, and they're based on counterproductive. Let me just say this about the healthcare exchange, and I think others will talk about it. Commissioner Chaney and the high-risk pool, under existing law in Mississippi, have the authority to set up a healthcare exchange. And they were well on their way to doing that. Mississippi was going to be one of the early states in the union to have a healthcare exchange. We were going to lead the nation. Had Mississippi established its own healthcare exchange, among other things, we would have had a call center in Mississippi. You know, the people that answered the phone would talk right. Yeah. We could employ people in Mississippi to answer the phone, and there'd be fairly high-skilled jobs because it takes some training to do this. Well, in one of the most bizarre moves that I have ever encountered, the United States Department of Health and Human Services paid some attention to this letter that the governor wrote and rejected our exchange, which may be the worst policy decision of the Obama administration. And, you know, there's some competition for that honor, but that was not a good move. So we, combined with the governor's opposition and that move, Mississippi doesn't have that healthcare exchange. We don't have those jobs, and we don't have a situation where it's easy for people in Mississippi without insurance to shop and get enrolled. There are other issues that I think anyone must deal with, what you do with a large number of uninsured people and on and on and on. But I simply want to make this point. If you disagree with the proposal about health care, that's fine. If you disagree with the Affordable Care Act, that's fine. But one has an obligation to have an alternative system, something that will work, something that would be a rational alternative to the Affordable Care Act. And I'll simply say it's very disappointing to see so many attacks on the Affordable Care Act and so much obstructionism just for short-term political gain and not for any real purpose.
I'm Tom Fenter. I'm the Chief Medical Officer at Blue Cross Blue Shield. I was, as some of the physicians in this room will tell you, I was a urologist. I was never a real doctor. So that's where I'm coming from. But also, I'm sitting between a senator and the commissioner. I don't know how I got this seat, but that's okay, representing an insurance company. From my standpoint, I look at it from the clinical side more than from the regulatory side. And you have to start with that this is a law. It has been passed and it's been upheld by the Supreme Court. So that's what we're dealing with at this point in time. A major concern for an insurance company in Blue Cross, and that's the last time I'll mention Blue Cross, is if you look at our healthcare system in this country, it is totally dysfunctional. It does not work, in my opinion. The other thing about the Affordable Care Act is it's an act passed for the United States of America, but I promise you, all medicine is local. What you can do with programs and things you want to accomplish for the citizens of Mississippi, you can't apply how things work in Boston, Massachusetts, to a rural area in Mississippi. So you have to think everything is local. And one thing, it is wonderful for people to have health insurance, but people, when they get health insurance or they don't have health insurance and they access our healthcare system in this country, 30%, 30 cents of every dollar spent on health care in this country and in this state is absolute waste. So 30 cents out of every dollar spent, it does not improve your health care. And I think that's one thing we have to focus on is where's the waste, how to get the waste out of the system, Because under the Affordable Care Act, the cost of health care is going up. The cost of premiums are going up. And how do we work together with the providers, with the regulatory system that we have to keep health care affordable? That's going to be a big issue.
I think I really ought to just take notes and not talk. I'm learning a lot I didn't know about him. I am Mike Chaney, your insurance commissioner, and along with what Senator Bryan has said about the state's ability or attempt to establish a health insurance exchange on a state basis instead of a federal basis, I have a staff that worked very hard to try to accomplish that. We actually operated a state-based exchange for about 4 months, and around 600 people that had bought insurance on the exchange until the feds denied our opportunity to operate a state-based exchange, and it was just unfortunate for us. But it is what it is. On the Affordable Care Act, if I had had a vote, I would not have voted for the Affordable Care Act, but it is the law. And my job as a constitutionally elected official and one who has taken an oath is to obey the law, and I intend to do that despite the disagreements. I will say, and I want to make this try to keep civility in it, as Governor Winter used to say during our Flag Commission days that Senator Bryan and I served on. The governor and I have agreed to disagree. Reasonable people can disagree about reasonable issues. But I do think we would have been better off with a state-based exchange versus what we have today with the federal government. To that end, Bob Williams, who happens to be in the audience today, our director in the Department for Health, and I submitted a letter to CSIO, which is a division of CMS and HHS, saying that we intended to operate a state-based exchange in 2015. I had originally copied the governor's letter on 2 drafts. I never heard from him, so we wrote a letter and didn't copy the governor. Probably my mistake, but we're back at the letter writing stage, and I was informed a week ago, Friday, that HHS will deny our application or our intent to operate a state-based exchange in 2015. That's very unfortunate for the state, but it is what it is. Along those lines, the CSIO group, through Gary Cohen, has said that they will probably deny every application that does not have the signature or approval of the governor, just due to the facts of what's happened in Mississippi. And let me backtrack and just say, in Mississippi, the issue was not that the governor had the authority to deny our ability to operate the exchange, but was the fact that the governor would not allow us to interface with the Medicaid to determine who was or was not eligible for subsidies on the exchange. If we had operated the state-based exchange, we probably could have saved the state over $250,000 a year just on what we pay out on Medicaid. If you think about the fact that when you pay out state dollars for Medicaid match, it's $2,000 to $3,000 per person that you put on. We could have put on maybe 60,000 at a minimum people below 138% of poverty on a state-based exchange, and I believe we can do that also with a federal exchange because of some waivers. But if you put them on the exchange and you can figure out how to pay the 2% requirement on the matching funds, it's not a lot of money, folks. We're talking about $12 to $20 a person. You save $2,000 to $3,000 per person you put on the exchange, and just do the math. You're talking about $150 million if you put 60,000 on. The pool is about 170,000. So it was something that we just couldn't sell the sizzle in the state. And I say that because when you ask people, what do you think about the Obamacare? 80% are against it. Well, what do you think about the Affordable Care Act? 75% are for it. It's how you ask the question and how you frame it. But that statistic's not mine. That's in Bloomberg's the last week in the Economist magazine for this week, if you want to look it up. But we're here to serve, and let me just quickly give you some stats. I don't want to talk very long. Mississippi signed up a little over 8,000 people. I found on the 1st of July we had 36 counties with no coverage. CSIO called us and said, if you will help us recruit someone to cover those 36 counties, will give you whatever you want. I wanted a state-based exchange. They didn't agree to that immediately, but they did tell Bob and I, that was his first day on the job, by the way, that they would give us a shop exchange if we were successful. And I don't think I should mention names here because I don't want to be too political, but we had some former governors, I should say, that called me and encouraged me to cooperate with the federal government. Some being Republican, maybe. I won't say that, but, well, there's only one alive Republican governor left, I guess, right now, other than the one we got. But we worked with SSIO. We got Humana to cover the 36 counties, and that gave us coverage in every county in the state. We were able to sign up a little over 8,000 people that have actually signed up to get coverage. We had about 31,000 applications that would cover 35,000 people. I want to compare that very quickly to Kentucky, a lot like us, but had a state-based exchange. Kentucky signed up, but I want to read my numbers correctly, 33,000 because they had a state-based exchange. If you look at someone like Rhode Island, which is a third of our size, had a state-based exchange, signed up right at 10,000 people that are actually in the system. So you see the difference between a state-based operation versus a federal operation. Hopefully, in the future, maybe in 2016, we can rectify the problem that we have today, but it is what it is, and we're working within the framework that we have to work in to try to implement the Affordable Care Act. Senator Bryan was very kind in his remarks about the call center, but he is correct. If we'd had a call center in Mississippi, we would have had one in the Delta and one in Jackson, Mississippi area. We would have expended somewhere close to $9 million of federal money to develop that call center and implement it. Instead, the state gave $1 million to do a call center upgrade in Hattiesburg. You hear what I'm saying? That's supposed to take calls for the Affordable Care Act. I'm not sure that's working yet, but there are a lot of things that we could have done if we had had a state-based exchange. But from this point forward, what we have concentrated on is a new option for health insurance, and that's to cover the shop exchange for small businesses in the state, to give them an opportunity to try to get tax credits, provide insurance for those businesses, especially from 50 or less employees. I will tell you, in our surveys, and Ms. Rigsby served on one of our committees, we found that over 2,000 people that we surveyed, that 80% thought that the number two thing that they needed to consider when they took a job were the benefits. And talking about health care. When you ask an employer what was the most important, benefits was down at number 4 and 5. Employees will leave the state of Mississippi if we do not have benefits and we cannot take care of them. On the issue of Medicaid, I've bitten my tongue many times, but I don't know enough about the Medicaid. I have to defer to my friends in the Senate and the House that understand it far better than I do. But when you have an uninsured population as large as ours, and we're not any different from our surrounding states, and you have so many people living on the edge of poverty, I think you really need to weigh the decision that has been made. It shouldn't be a decision that's made politically. It should be about pragmatic facts. It should be about people and how it would affect the state of Mississippi, not only now but in the future. So that's a big issue. There are people on this panel that can answer that question better than I can.
Thank you. While we're on the subject, the sunsetting of the state-sponsored exchange, what is the reality there, Commissioner Chaney?
We will not have a state-based exchange. We just CSIO told us that you're not going to get one without the governor's signature, and I just don't think that's going to happen unless I can do a lot of praying about it and have a miraculous miracle or something. I don't think he's going to grant us the authority to operate an exchange. So I just think it's out of the question, Dr. Alford.
Brief commercial. Teresa Hanna, who heads up our objective thinking body along the healthcare realm, the Center for Mississippi Health Policy. She has some briefs here that include some important information about a lot of these topics that we're talking about, including Medicaid expansion and the state exchange. One of the, we're going to sort of be going back and forth here in the few minutes that we've got remaining. One of my concerns amidst all of the health care are our inability or our malaise or our inability to sees some of the positive elements of the health policy. In Kosciuszko, where I practice, which is a fairly typical rural community, and let's remember the majority of Mississippi is rural. We have 20 counties in this state that are 100% rural. We have 57 counties that are at least 50% rural. That makes up a large portion of the population. These communities are very dependent on educational resources as well as health resources. The burden on our emergency room now in Kosciuszko, I asked our administrator shortly before I left, we have a 22% uninsured, uncompensated rate that presents to our emergency room. The reality of this is that when the health care law went into effect 3 to 4 years ago, and the federal funds, better known as the DISH funds, began to dry up, the theory was that that difference would be made up by the fact that we would have all of these people insured. Well, they're not. And so what's happening in reality is, in the rural communities, is we will see incredible stresses placed on the rural hospitals. And Governor Winter has said more than one time that per capita income is tied directly, unequivocally, and irrefutably to education. Per capita income is also linked to the health of a population. And we now know that in rural areas, the hospital system in a rural community on average across the U.S. means around $700 per capita for every man, woman, and child in that community. So last week, our local board went to the Board of Supervisors for the first time in its history to ask for a line of credit so that it will be able to meet payroll. Now, imagine what's going to happen across this state as rural hospitals begin to implode. There's going to, if you haven't been to an emergency room in an urban area and seen the congestion in an emergency room, and all of a sudden we start displacing more of these patients into the urban settings, how much of this reality has got to come into our clear line of vision before we actually begin to take some action? I wanted to ask Senator Bryan if, because I think I've heard him remark on this, just how much money we're talking about right now that we have already surrendered because of our melees or inaction or resistance. How much are we talking about? Can you put that in terms we can all understand?
I'm sort of at a disadvantage because I'm not sure of the knowledge of the audience about all this stuff. I don't know if everybody here is really up to speed on the Affordable Care Act, and they can, toss these questions up and catch them behind their back, or if we've got normal people who are living normal lives and not are consumed by this. But basically, the Affordable Care Act, like it or dislike it, is a unified approach, and if you put it together, it's rational. What has happened as a result of the Supreme Court decision and a result of unanticipated obstinance on the part of various states is first one thing and first another is then being pulled out of it, and what's left is odd. As a result of the Supreme Court decision, states can opt out of Medicaid expansion. And the theory of the act is for people who or whose income is low up to a certain point, you'll all get Medicaid. Then from this point on, you'll get a subsidy to buy health care, and the subsidy originally, if your income is low, is very high, and then it averages out, and that's the method of getting universal coverage. When Mississippi and other states opt out of the Medicaid expansion, that means that there's a group of people whose income is so low they don't qualify for the subsidy on the exchange. So you're too poor to get the benefit of this program. It's completely irrational. The Medicaid expansion population would be paid for in the early years 100 cents on the dollar with federal money. And there is no requirement that any state participate long-term. So as of today, every day that passes, the state of Mississippi is foregoing more than $1 million of federal money that could be coming to the state of Mississippi to provide health care for people who are sick and poor and can't afford health care. $1 million a day plus, and every day that passes, just so the governor can prance around and say, I'm not implementing Obamacare. We are turning down more than $1 million a day in federal money that would have zero cost to the taxpayers in Mississippi, and we are allowing hundreds of thousands of Mississippians to suffer without health care. Now, that just does not make sense. Furthermore, ultimately, way down the road, eventually the states would have to put up 10 cents on the dollar for the expanded population. Listen to me. When you put $1 into Mississippi's economy and spend it on health care, by the time that money turns over in the economy, by the time you have more people that are employed and people spend the money and pay taxes on it, and the money works its way back to the state treasury, it's way less than 10 cents on the dollar. If you had to pick a figure, it'd be something close to maybe a nickel on the dollar. If that would be the additional cost, and that's in the out years. And we don't even have to agree to participate in the out years. And for that amount of money, we are allowing hundreds of thousands of Mississippians to go without coverage, and we are putting providers in Mississippi, in particular hospitals and others, in a position where it's hard for them to keep body and soul together, because this was the method of providing enough money to the hospitals so they could continue to operate. It's the most inexplicable, counterproductive thing I've seen down here, and that's saying a lot. Since you asked.
So, Dr. Fenter, and Tom and I go way back. In fact, he is a urologist, but I can tell you that Tom has actually come to probably the last 10 out of 10 family medicine meetings that we have on an annual basis. And I think a lot of the concerns, needs of primary care, Tom has embraced and understands from his position as medical director of Blue Cross the importance of primary care enhancements. One of my heroes, Barbara Starfield, who died June of 2011, who was a pediatrician by training and wound up running the School on Public Policy at Johns Hopkins, who is a strong advocate for primary care, did amazing research that demonstrated, and these are her words, a freely chosen primary care doctor, preferably over several years, is associated with better care, more appropriate care, better health, and lower cost. So what we have been talking about is access to a system that is in a large way broken. Tom, do you have any comments about that as far as the quality measures that are either inside or not inside the law?
Well, if you're going to get at the cost of health care, at least in my opinion, you got to get at the word quality. And where is that health care delivered? To answer the emergency room question, that's the most expensive place to go for health care anywhere in the United States, so we want to keep you out of the emergency room if we can. But I think the backbone of health care in Mississippi has to be in the primary care world. We don't, and I'm not stepping on toes, I hope, we don't need 100 new orthopedic surgeons in Mississippi. We need 300 or 400 primary care physicians and probably 1,500 to 2,000 more. But the issue with primary care, in my opinion, is we have to find a way to restructure how primary care is practiced in Mississippi and around the country. And we have to find a way to free up that primary care provider, physician, to take care of the sickest people in their office and then let other types of health care providers in their office handle the routine. If you got the flu, it's not routine, but you got to go. The routine colds, are you getting your immunizations? We got to find a way, and we also have to find a way, which I think is critical in this state of Mississippi. We have to find a different way to pay the primary care provider for their services. They need to be paid for quality, not just fee for service. Did you do the hemoglobin A1C? Did you counsel that patient about diabetes? Well, I don't have time. Then it's important to find a way to put a dietitian in some of these offices. But it's going to change the payment system and incent them to spend more time on their chronic illnesses and give them the extra help they need in their offices to take care of people.
So understand, we are, as physicians, we are working under a lot of regulatory burden. And meanwhile, Mrs. Smith just passed out in the waiting room, and Mr. Jones just presented to the emergency room with a heart attack. So the Affordable Care Act has provided quite a number of regulations which are cumbersome, and the instrument of the day is the electronic health record, which I feel like the future is bright for it, but it's been rather dark working through that the past 2 or 3 years, and it's hard for me to put my finger on elements of that, the utility of that are meaningful to quality outcomes. We are working to try to put those measures into place. So the Affordable Care Act really has to do more with insurance and how people are able to get coverage to go to their physician, and not so much with the brokenness of our system. And a lot of that brokenness, it is thought, and Tom has just alluded to this, is the way that we are paid. We are paid on a fee-for-service methodology rather than a universal charge that rewards physicians for good clinical behavior and good clinical outcomes. And if you go to saying that too loud in the company of my colleagues, you can get run out of town. This is going to be a relatively...
Or shot.
This is going to be a relatively traumatic time in the medical profession, because we've got to come to terms with the realities that we are pricing ourselves out of the reach of many whom we claim to want to help. And we've got to develop affordable means for people to pay their bills. I don't know if anybody has had a chance to pass a question down. Kenny, have we got any questions thus far?
How about everybody pass them to your left, and I'll select the question. Pass them to your left.
Do we have any? We've got a few minutes remaining. We can take questions from the audience. Yes, sir. Dub?
You and Senator Bryan and the others, what in your judgment as experts or involved people, what are the odds of fixing it?
Well, when you say when you say how are we gonna fix it? What are the odds of fixing it? Maybe Senator Bryan could enlighten us about that.
Well-
You know, my feeling about that is, and then Senator Bryan can give his opinion, is that we may not, all of us, some of us in this room may not be on the same timetable. You know, when Medicaid came into reality in the state of Mississippi, that was a 4 or 5 year evolution. It took about that long to bring our political leadership along. And, but there was a moment of enlightenment that had more to do with the reality of turning our backs on the money that would come to the state. And so the timetable, I think, is an issue. My feeling is that I don't hold out a lot of hope until after the midterm elections, or at least until we get past the primaries of midterms, because so much of the ideology is tied up in this discussion that we're having today. But I do think that those of us that can and should try to prepare the minds of our leadership. We have an obligation to do that and to continue to pound the drum that we have a huge uncovered portion of our population, and it is putting a drag on the economy of this state. And other states around us are seizing the opportunity. So those cold, hard realities, for example, we mentioned Kentucky. They have a Democratic governor. They are taking the Medicaid expansion money, and they are finding the best way, the sweet spot between Medicaid and the state-sponsored exchange. And they will be at a competitive advantage when it comes to recruiting and retaining primary care physicians. In my office, we have 5 to 6 to 7% of people come in who have no means of payment. Now, that sounds like a lot, but again, I said the emergency room has 22 to 23%. So the default for these people is to the emergency room. Those costs get passed on to our local hospitals and to our local governments. So it's pay me now or pay me a lot more later is what it's amounting to. And how much, to me, the business community, the economic community has got to try to help make the case. And to be quite honest, I think my own profession has been AWOL on this issue. I think we have done a disservice by not being more involved in this discussion than we've been. And I can say this on my home campus. Tom, go ahead.
Yes, the question, how long? I think sitting where I sit and practice medicine, and I'm a patient taking some medicines, that's a HIPAA thing, but I won't go there. But we got to change the culture. We have got to have leaders like, excluding me, you have at this table. If you're waiting to treat diabetes, it's too late. We've got to start with our children in this state and work our way up to healthy adults. If we don't do that, there's not enough money around to take care of all the disease that we're going to see. So how do you take a generation and change it? Just a step at a time. It's not going to be easy, and it's easy for people to say that and everything else, but we've got to have leadership in all the communities and the churches and every place to teach our children and somehow get it affordable so they can buy the good food and that sort of stuff. And until we change that, we're always going to be treating the end results of an unhealthy lifestyle.
Have a moment left. I've got a few questions that how much time we got left?
Go about 10 more minutes.
About 10 more minutes. A question from the audience. Dr. Fenter, is Blue Cross planning to join the federal-run insurance exchange?
We did not elect to be on the exchange this year. There was some reasons for that. We were working with some of the people at Blue Cross, were working with the commissioner on an exchange. But when it became clear that there was going to be a federal exchange, the leadership at Blue Cross, we didn't know what the rules were, what was going to be out there, what you were going to have to do, what you would be required to do. Our IT people that were in some of the meetings on a national level came back and told us the exchange would not work on the federal level. They were using 10-year-old technology to begin with, and there was no security. That was just their observation of how this thing was going to play out. So we elected not to do it this year. We will evaluate it again, depending where we are, and whenever that comes up in this year, but we're not there, and that's the reasons why.
Anybody want to take this one? We know what's wrong. We've articulated that, so what are we going to do? What do we do now? Anybody want to take that one?
I'll respond to that. I'll start. Senator Bryan already laid the groundwork for Medicaid expansion and what that means. I just want to put some numbers to that context. That is expanded Medicaid in our state. We have 20% of Mississippians who are uninsured. It's a lot of people. And expanded Medicaid is an opportunity to help these folks have access to health care. We're talking about 280 to 300,000 people. These are people that cut our hair. These are food service workers. These are contractors. This is jobs. We're talking about jobs as well. We talked about the economy and how this is going to stimulate the economy. We are talking about the potential to have thousands and thousands of jobs in Mississippi if we expand Medicaid. So we're talking about the economy, we're talking about people, we're talking about access to health care for these folks. And it makes Mississippi much more attractive to do business. When you look at the surrounding states who are expanding Medicaid, and you look at our tax dollars, our federal tax dollars are going to other states, that's going to help them to make their Medicaid programs better and increase health care to access to health care in their states. So I think it's really important that we continue to push to expand Medicaid. The first 3 years, the federal government is providing full funding to states to expand Medicaid. Thereafter, it's 95% and up to 90% through the year 2020. So I think that's a huge opportunity for us to help fill that coverage gap to folks who make too much for the traditional Medicaid program, or they're not eligible for that program, and those who can't afford health insurance through the exchange.
I have another question here.
Let me tackle
Okay,
that.
I'm sorry.
I'll do it in 30 seconds. Dub, I know you're still a reporter. I just want to. Has been, okay. I would do 4 things, and this is the first public statement I made on this. I would take the Medicaid dollars. Unless there's a compelling reason that I'm not aware of, I think the state should take the Medicaid dollars. I'll break with a lot of leadership on that, but you got to remember, I live in a fishbowl, and I have to pass legislation and work with the legislature, so I've been low-key on that issue. It's not something I regulate. It's not in my purview, but when you leave $1 billion on the table, it's not real smart. And when you think about the fact that Mississippi's threshold is $5,500 or something like that to get on Medicaid, if you make more than that, you can't get on. You've got a large segment of the population that could use help. The second thing I would do is I would go back and use the private exchanges that exist today that are not broken, that are using current technology, and I would interface those private technology exchanges in with the federal government's criteria for eligibility. That can be done in about 90 days. It could be done in parallel with the system that they have today in Washington. It would be interested if you would just sit down and read the GAO report about what happened and why the White House has done what they have done, which I think was a smart move on their part, to go out and hire a private contractor to try to fix the problem with the webpage. We had less than 800 people signed up through Christmas. And within 2 weeks after they got the new web page up and running, we had over 7,000 people that got qualified to buy insurance. The third thing that you need to look at, you've got to change the way that we do networks. You've got to change the way that we deliver health care. Instead of fee-for-service, you've got to have quality and outcome. When you look at the way we're headed to a single-payer system, I hate to say that, but you can have a bifurcated system if you work at it. I think the issue there is whether or not the medical profession would agree with us on that issue. But the idea here is you lower the insurance cost. Quick example, Mississippi had about 80,000 people that could be counseled under the federal rules on October 1. We worked with Blue Cross, United, all the carriers actually, and said, why don't you renew, give the people the option? And Blue Cross came to us with the letters, we vetted them out. Bob Williams, being a former VP out there, helped me work through the area. And instead of saying we're canceling your policy, we said we're going to give you the opportunity to renew your policy at less than 5% as an individual through October of next year. Not cancel, just you got to renew it, and you got to sign here if that's what you want to do. If you're a group, it'll be less than 10% increase in your policy, and you get it through December of 2014. The feds are going to allow us to look at that again, and what we did is we avoided the bullet. Louisiana counseled 95,000 policyholders because they waited too long to address the issue. So there are some things that you can do out of the box to address the issues today. I'm not going to get into the networks. It'll take way too long, but that's a little longer than I wanted to go. But that's
Thank you.
kinda where we're
Thank you. I would like to direct this last question, then I'm going to have a closing remark to Dr. Fenter, because this actually comes from somebody in the audience who's obviously a pre-med student. So I'm going to recouch this question. If you were a pre-med student at Millsaps College today, ready to attend medical school, what would your thought be?
My first thought is you're going into a wonderful profession. The profession is not going to change. I mean, it's a lifelong, wonderful thing, and I've been blessed to be able to be part of that profession. I will tell you what at least from my standpoint, is how you earn your living is going to change. You most likely, in my opinion, this is not Blue Cross, you're going to be an employee of a hospital or a large corporation providing health care. You'll be on a salary. It'll be a good salary, I would think. You'll be able to make a living, but the way you get paid is absolutely, as I said, going to change. If you want to talk about what specialty you need to go in, talk to me offline. I'll be glad to talk to you about that. You know, there are some specialties you don't want to go in right now, in my view. You got a great future ahead of you, and just get yourself prepared, because you might make a little less money. I'm not sure about that, but I will promise you the rewards of practicing medicine are there, and that is not going to change.
Tim, if I were a pre-med student at Millsaps today, I would remember that age is best which is the first when youth and blood are warmer, for being spent the worst and still worse times succeed the former.
Nicely put.
It's not original.
And since you've cut me off so many times, I'm now going to cut you off, and I'm going to close with this, Senator Bryan. Thank you for your eloquence. It never ceases to amaze me. So this is a church-affiliated institution, and we have been through a week of honoring Martin Luther King, and Martin Luther King's comment about the church is that it is not the master of the state, nor is it the servant of the state, but it should be the conscience of the state. And so I hope that this brief time that we've had together, your conscience has been raised a bit, because I do think that awareness of the truth and the science of this whole discussion is important as we move on. It may not happen as fast as it would happen, but I think it's inevitable that some good things are going to happen. And this is really my last closing remark in honor of Governor Winter and Elise. I'm going to quote from one of his remarks that he made in 1994. I can tell you that in spite of all the problems, real and imagined, that seem to plague us, these are good times, maybe the best. If it seems that they are not, maybe it's because we have forgotten the pain and sacrifice that have brought us to where we are. And so instead of engaging in mindless pessimism and self-centered deceit, let us, with enthusiasm and excitement, move to the unfinished work, to a more fair and more compassionate society, and be thankful that we can have a hand in that noble task. Thank you for coming this afternoon, and some of the panelists may be around to answer questions. Good day.
We didn't get off on the